Good morning, student. I am Dr. Bhupendra Shah, Assistant Professor of Department of Internal Medicine. Today, we learn about jugular venous pressure. So, objectives of today's discussions are: we learn about the anatomy of the jugular vein. Similarly, we will also discuss about the waves in JVP, how we are supposed to measure the jugular venous pressure, what is the effect of respiration over JVP, and what is hepatojugular reflux. We are not going to discuss about the different abnormalities in JVP in different disease condition. Why I have make this presentation? Because as a teacher of the medical student, I think students feel so much uncomfortable while reading this chapter. They have confusion over different terminologies of JVP. So we will try to make it simplify. So let us go one by one. Anatomy. So this is our heart. This is in the heart there are four chambers. This is right atrium, this is left atrium, this is right ventricle, and this is left ventricle. This is tricuspid valve, this one is the mitral valve. In the right atrium there is a drainage of the inferior vena cava as well as the superior vena cava. Superior vena cava is formed by the brachiocephalic vein. Brachiocephalic vein. This is right brachiocephalic. This is left brachiocephalic. Brachiocephalic. In the brachiocephalic vein, there is a tributaries like internal jugular vein and external jugular vein drain. Similarly, in the left there is also the internal jugular as well as the external jugular. So superior vena cava is formed by the right brachiocephalic and the left brachiocephalic. In the right brachiocephalic there is a drainage from the internal jugular vein. This is internal jugular vein, this is external jugular vein. So when we are measuring the jugular venous pressure, we prefer the right internal jugular vein. Why right? Why not left? As you see in the figure, the right internal jugular vein is in a straight line with the right atrium. That's why we prefer the right internal jugular vein. Similarly, why not external jugular vein? There are arguments that you can even see the JVP in the external jugular vein, but we usually prefer the internal jugular vein. We see here the right external jugular has the two right angle here. So while before coming to the superior vena cava, it has the bending by 90 degree in two places. So it may not measure the JVP exactly, whereas the right internal jugular vein is in the straight line. So your answer should be right internal jugular vein is in straight line with the superior vena cava and the right atrium. That's why it can reflect the pressure changes in the right atrium. That's why we prefer the right internal jugular vein for the estimation of the jugular venous pressure. Some books say there is no valve in the internal jugular vein, but the latest updates are there are definitely the valves even in the internal jugular as well as the external jugular vein, but these are the functional valve. Okay, so even the internal jugular vein contains the valve. These are the functional valve, and it doesn't make difference in the phasic flow of the blood from internal jugular vein to the superior vena cava and the right atrium. Okay. So from the anatomy section, what we have learned? We have learned that we are supposed to see the jugular venous pressure in the right internal jugular vein, because it is in straight line with the superior vena cava and the right atrium. Though we can see the JVP even in external jugular vein, but as we see in the picture that it has sharp bending of 90 degree in two places, so it may not reflect the exact pressure of the right atrium. Okay, then what are the waves of the JVP? So the waves of JVP are, this is the A wave, this is C wave, this is X descent, this is V, and this is Y. This is A wave, this is X descent, this is C, this is V wave, and this is Y. These are the waves of the JVP. Then what is the mechanism of the A wave? A wave, as you can see in the picture, this is your heart, this is a very simple diagram of heart, and we are trying to estimate the pressure over here in the internal jugular vein. So A wave is formed when the right atrium contract. When it contract, some of the blood will goes to the right ventricle, but it will increase the pressure at the right atrium, and that pressure is generated back to the right internal jugular. That's why we see the positive deflection in the JVP. That is what we call the A wave. So A is because of the atrial contraction. Once the atrial get contracted, then atrial start relaxing. Atrial started relaxing. Once the atrial is relaxing, then there will be a drop in the atrial pressure. This drop is denoted by the X wave. So that's why there is an X descent. It's because of the atrial relaxation. But in between, what happens? This after atrial contraction and like atrial contraction is there, atrial relaxation is going. Then there is the ventricular contraction. When the ventricle contract, it will close the tricuspid valve. When it closes, when it contract, it closes the tricuspid valve and it exerts some pressure over the tricuspid valve, so that the tricuspid valve anatomy will be like this. It will take the C-shaped. When it takes the C-shape, it will increase again the right atrial pressure. That's why there is slight positive deflection here. That is C wave. So C wave is because of the ventricular contraction that results the bulging of the tricuspid valve over the right atrium. So this is because of the bulging of the tricuspid valve. So another factors that is responsible for the C wave formation is when the ventricles are contracting, it ejects the blood in the aorta and ultimately to the carotid arteries. From that carotid arteries, pulsation can come to the jugular veins. That's why we see the C wave. So A is atrial contraction, X is atrial relaxation, C is ventricular contraction leading to the bulging of the tricuspid valve. When the ventricular is contracting, then after some times, like it get relaxed, and atrial is also relaxing, ventricular is also relaxing, and there is a filling of the atrium by the blood. Atrial filling, there is a filling of the atrium by the blood. Now the scenario is like that: tricuspid valve is closed, then the atrium is relaxing, and the blood is coming towards the atrium from the systemic circulation. When the blood is coming to the atrium from the systemic circulation, then it will definitely increase the atrial pressure. That's why we see the V wave here. Once all the blood come to the atrium, then the tricuspid valve opens, and after opening of the tricuspid valve, all the blood from the atrium then moves towards the right ventricle, and that leads to the decrease in right atrial pressure. That's why there is a Y descent. So let us make it simple. So A is because of the atrial contraction, there is increase in atrial pressure. C is due to the ventricular contraction that leads to the bulging of the tricuspid valve. X is because of the atrial relaxation that decreases the atrial pressure. B is because of the atrial filling. Once atrial get relaxed, it has to be filled by the blood. So that's why there will increase in atrial pressure. That's why you see the V wave. Once atrial is full of blood, then your tricuspid valve should open. So when the tricuspid valve opens, then there will drop in the atrial pressure. So that's why that is what you can see in the JVP. That is what we call the Y descent. So this is atrial contraction, ventricular contraction, atrial relaxation, atrial filling, and tricuspid valve opening, and passive flow of the blood to the right ventricle. This is how the waves are formed. But how to recognize this wave? So you look at here, this is because of tricuspid valve, bulging of the tricuspid valve near about this point. So what is the mechanism of the first heart sound? The mechanism of first heart sound is closing of the tricuspid and the mitral valve. So at this point of the time, when the tricuspid and mitral valve close, you will auscultate the first heart sound here, S1. Tricuspid valve close first, okay, that's why this is the point where you will get the S1. And here, so in the V wave, when before opening of the tricuspid valve, there should be the closure of the pulmonary and aortic valve. So you will hear S2 here. So the waves which is just coinciding with first heart sound is the C wave, and the wave which is just before the first heart sound is the A wave. You can also correlate with the heart sounds, auscultate. You can auscultate with the heart sounds. Heart sound, okay. So let us revise it again. So where do you look at the JVP? Sir, we are supposed to look at the JVP at right internal jugular vein. Why? Because it is in straight line with the superior vena cava and the right atrium. That's why we look the JVP in the right internal jugular vein. So though there is a presence of the functional valve, but this does not impede the phasic flow of the blood from the right internal jugular vein to the superior vena cava and the right atrium. What about the right external jugular? Definitely we can see the JVP in right external jugular vein, but there is the sharp bending of the right external jugular vein by 90 degree in two places before coming to the superior vena cava, so it may not exactly reflect the pressure of the right atrium. Then we have also learned about the waves of JVP. There are three positive waves, that is A wave, C wave and V wave, and two negative deflection that are x descent and the y descent. A wave is because of atrial contraction, C wave is because of the ventricular contraction, X is because of the atrial relaxation, V is because of the atrial filling, and Y is because of the tricuspid valve opening. So these are the mechanism of these waves. Then how to measure the waves? JVP. So to measure the JVP, you can measure the JVP in any position, whether the patient is in supine position or sitting position or sometimes standing position. You can measure at any position, but preferably we ask our patient to sleep in a 30 to 45 degree position. In this position, we prefer. Okay. So and when you are like sleeping in a 30 to 45 degree position, you have to ask your patient to turn their head to the opposite side, near about 45 degree, opposite side. It should not be too tense. If it is too tense, then sternocleidomastoid mastoid muscle can occlude the jugular venous pulsation. So it should be only near about 45 degree. Okay. Then you ask your patient to take the normal respiration, and you take the two cardboard like structure. So two cardboard like structure. So for two cardboard like structure here. Okay. Then what you have to do? You have to do from the external angle. You know how to recognize the external angle. External angle is where the second ribs, where there is the attachment of the second ribs, or it is the point where there is a meeting point of the manubrium sterni and the sternum here. This is the external angle here. You can easily find out the external angle. From that external angle, what you have to do, you have to keep one cardboard like this perpendicularly to the external angle, and another cardboard from the height of the pulsation like this here, and you can measure this height. Okay. So this cardboard should be at the level of external angle, perpendicular to the external angle here, and another cardboard should be from the height of the jugular venous pulsation here. Then you can measure this height. So let's suppose that height is 6 centimeter. Let's suppose this height is 6 centimeter. Then what is the JVP? So JVP is, you have to add 5 centimeter. Why you have to add the 5 centimeter? Because from the external angle to the right atrium, from the external angle to the right atrium, from the midpoint of the right atrium is the 5 centimeter. This is standardized. Though it may not be true for each and every patient, it is standardized. So from external angle to the mid portion of the right atrium is the 5 centimeter, and it is usually, we take this value constant for everyone. And what we have to measure? We have to measure this part. If this height, if it is 6 centimeter, then your JVP is 11 centimeter of water. You have to say 11 centimeter of water. But if you have to convert into mm of Ag, then you have to multiply that by 0.736. 0.736. You have to multiply by to convert into mm of Ag. So when we are measuring the JVP, you usually get the value in centimeter of water. Okay, centimeter of water. If you have to tell that in mm of Ag, just multiplied by 0.736. Okay, this is how you convert the centimeter into millimeter of mercury. Okay, Let us revise it again. Why you take the 5 centimeter? Why you take the 5 centimeter? Because 5 centimeter is the distance between the sternal angle and the midpoint of the right atrium. Okay, so how to identify the sternal angle? What is sternal angle? It is the meeting point of the manubrium sterni to the sternum. So you can easily identify the flat part over in the chest, the flat part. Okay, then you have to measure this height by placing the two postcards or two scales. You just measure that and at 5 centimeter. You will get the JVP in centimeter of water. If you want to convert into mm of Ag, just multiply that by 0.736. And one thing I forgot is that like you have to keep your patient in 30 to 45 degree and just ask them to turn their head to the opposite side, and you have to throw the light from the posterior side tangentially to the pulsation. Okay, tangential to the pulsation. Okay, through the light by the torch light. Okay, that's how you can see the pulsation there, and you can measure the height of the JVP. Now this is how. So what is normal JVP? So normal JVP we usually take is 5 to 8 centimeter of water. If it is more than 8 centimeter of water, we can say it is elevated JVP. If the JVP is more than 8 centimeter of water, we can say there is elevation of the JVP, and the cause of the JVP elevation are like in case of the tricuspid stenosis or right ventricular failure or biventricular failure. There are so many causes, pulmonary artery hypertension. But if it is more than 8 centimeter of water, then we can say JVP is elevated. But most of the students have difficulties. Oh, it is jugular vein pulsation or carotid artery pulsation. So sometimes it's very difficult for the medical student. For that, what you need to do is that for the location, for the JVP and the carotid artery. So location wise, where you have to supposed to see? Location wise, in between the two head of sternocleidomastoid mastoid muscle, you will see the JVP in between the two head of sternocleidomastoid mastoid muscle, sternal head and the clavicular head. Where as in the carotid, we will get in the medial side of the sternal head of sternocleidomastoid mastoid muscle. You will get the carotid artery pulsation over here. So JVP pulsation is between the two head of sternocleidomastoid mastoid muscle. One. Second is, in the JVP, as we have already discussed, there are two positive deflection in each systole. So there is A and the V. Whereas in the carotid artery pulsation, there is only one positive deflection. So two positive deflections suggest JVP, only one positive deflection in a systole suggests carotid artery pulsation. Third, and for me it is one of the useful thing to differentiate the JVP is that usually JVP varies with the respiration and the position of the body. So when you are inspiring, your JVP falls down. When you are standing, your JVP falls down. But that doesn't make any impact over the carotid artery pulsation. So just if there is a pulsation, just ask your patient to take a deep breath. If there is a fall in that pulsation, then you can say it's a JVP, or ask them to stand. If there is a fall, then it's JVP, otherwise it's the carotid. Then JVP is better seen, whereas carotid is better palpable. You can easily palpate the carotid artery. So sometimes it's very confusing. In that scenario, what you have to do, you have to give the pressure over the medial, just over the medial end of the clavicle here. Just give the pressure over here. If that causes the, like if we press over there, and if there is a like the JVP pulse go away, then you can say it is because of the JVP. If there is a pulsation even after pressing over here, then you can say it may be the carotid artery pulsation. Okay. So this is how we have to differentiate the JVP from the carotid artery. So location wise, the JVP lies in between the two head of sternocleidomastoid mastoid muscle. In the carotid artery is the medial side of the external head of the sternocleidomastoid mastoid muscle. Two positive deflection in JVP, one positive deflection in carotid artery. JVP varies with respiration and position, whereas carotid artery pulsation do not vary with the respiration and position. We can occlude the JVP if you give the pressure over here but we cannot occlude the carotid artery pulsation. This is how we can differentiate the JVP from the carotid artery pulsation. Okay. Then what is the effect of respiration over JVP? When we are inspiring, what happened? So there is drop in intrathoracic pressure because there is your palatal pleura go away. So there is drop in intrapleural pressure, and that also led to the drop in the intrapericardial pressure. So overall there is a drop in the intrathoracic pressure. So if there is drop in intrathoracic pressure during inspiration, it shocks the blood from the jugular veins. So when you are inspiring, then there will be a drop of the jugular venous pressure by at least 3 cm of water. So when you are inspiring, it causes the drop in intrathoracic pressure and it will cause the drop in JVP by 3 cm of water. This is the normal phenomena. So this is the effect of respiration over JVP. But there are some conditions where there is no fall in JVP. Instead, there is rise in JVP during inspiration. We are inspiring, but there is rise in JVP, or there is no fall by 3 cm. Then that sign is called the Kussmaul sign, and classically you will get this type of sign in a patient with constrictive pericarditis. So normally there should be fall by more than 3 cm when you are inspiring. Okay, this is the normal physiology of the JVP. So last one is the hepatojugular reflux. So sometimes we have to do the hepatojugular reflux. We have already discussed in the right atrium. There is also the drain from the inferior vena cava, and one of the tributaries of inferior vena cava is the hepatic veins. So if you are pressing over here in the liver, in the right upper quadrant, you are compressing the veins over there, and it will cause the what it will do, the blood from the liver will go to the right atrium over here. When the blood is going towards the right atrium, then there will increase in the right atrial pressure, and that you can see in the JVP. Okay, there will be elevation of the JVP. So when you are giving the sustained pressure by more than 15 seconds, it will cause the raise in JVP. It will cause the raise in JVP by near about 1 to 3 cm of water. It is a normal phenomena, and that is usually for less than 15 seconds. So there can be the raise in JVP if you press over the right upper quadrant for near about 10 to 15 seconds by 1 to 3 cm of water, and for the less than 15 seconds, this is the normal phenomena. But if there is a problem over the right atrium or right ventricle, if there is already increase in pressure, then what happens? There will be the increase in JVP by more than 3 cm and for more than 15 seconds. Then this is called the positive hepatojugular reflux. This is called the positive hepatojugular reflux, and it can detect the incipient right-sided heart failure. That's why when you are assessing the JVP, you should not forget to assess the hepatojugular reflux. For that, you just have to press over the right upper quadrant for 15 seconds and just see what is the level of elevation in the JVP and for how much time. Okay, if it is more than 3 centimeter and for the more than 15 seconds, you can say there is positive hepatojugular reflux. Okay, this is the some of the basics of the JVP. So let us revise it again. So why you look the JVP in the right internal jugular? Because it is more straighter. It is more straighter than other veins in regard to the superior vena cava and the right atrium. Do you think it contains the valve? Yes, sir. Internal jugular vein contains the valve, but that's only the functional valve. It doesn't impede the phasic flow of the blood flow from the internal jugular to the superior vena cava and the right atrium. You can definitely see the JVP in the external jugular vein, but there can be some error while assessing the JVP in external jugular vein because it has the sharp bending by 90 degrees in two sides. Then there are the wave. There are different waves in the JVP. There are 3 positive waves: A wave, C wave, and V waves, and 2 negative waves, that is X and Y descent. A wave is because of the atrial contraction. C wave is because of the ventricular contraction. X is because of the atrial relaxation. V is because of the atrial filling, and Y is because of the atrial inting after opening of the tricuspid valve. So how to locate these waves? You just have to know the first heart sound. You can auscultate that. The wave which is prior to the first heart sound, before to the first heart sound is the A wave, and after to the first heart sound is the C wave. The wave which is coinciding with the second heart sound is the V wave. This is how you can identify the waves in JVP. Similarly, carotid artery pulsation is usually coincides with the C wave. Carotid artery pulsation usually coincides with the C wave. Then we have also discussed some of the difference between the JVP and the carotid artery pulsation that we have to know. An effect of respiration: with the inspiration there will be a fall of JVP by 3 centimeter. This is a normal phenomena we have discussed, and we have also discussed about the hepatojugular reflux. These are some of the basics of the JVP. If you have any comments, any questions regarding JVP, you can write. If you people are interested, then definitely you can make another video on JVP, which will be basically on what will be the JVP finding in different disease condition. Thank you so much for your kind attention.